Bismillah ar-Rahman ar-Rahim. So today we're going to be starting off with a revision of the chest imaging. So if you watched the previous videos, I've uploaded 4 videos in regards to chest imaging or the basics of chest imaging and radiology that can be watched by any medical student and even interns. I didn't go over all of the basics, but it covers some of the most common things that we might encounter as medical students, as interns. Of course, there are some advanced stuff, but that will be for residency purposes in radiology. So in our episode number 5, we'll be reviewing some of the cases related to chest imaging, specifically on chest X-ray. And especially those in internal medicine and even those in surgery, but mostly in internal medicine. So there are obviously a couple of cases here that I got it from a PowerPoint slide in my curriculum in regards to internal medicine, and we'll look at them one by one. So of course, a lot of the slides explains a lot of the basics of chest X-ray. Again, you can look up previous videos that I've uploaded on the YouTube channel to explain it in better detail and really apply some of the information. So we'll just look at some of the cases in this PowerPoint slide. So here is just telling you what are the differences that can be seen here from the same patient. So we have a chest X-ray over here and another chest X-ray of the same patient. So the clear difference between the two, as you can clearly see, one shows the heart being larger in size, so the magnification is bigger here, and the other one is not. The other one shows that the lung fields are hazy, they're not as clear, they're not as black, consisting of air as compared to this picture. And you can see that the diaphragm over this one, the right and the left hemidiaphragm, you can see that they're much more elevated as compared to the picture on the left. So when you compare these 3 differences, you can explain it by simply two words, and that is the view. So this one, the picture on the right, is an AP view. Typically, patients are lying supine, and they'll be having the radiation source right in front of their chest, and it will have radiation coming from the front and back, and coming from the front and then towards the back, an AP view. Well, the picture on the left is a PA view, or often the source of radiation where it's going to be shooting will be the opposite. It will be from the back, so it will be a PA from the back and then towards the front, so a PA view. The idea behind this is that you should always get a PA film to avoid cardiac magnification, because sometimes you might think this patient has cardiomegaly in this AP view, but it isn't. So it's always preferable, it's not always the case, but it's always preferable to order a PA film. The patient is lying not supine but erect position, he's standing and he's taking full inspiration to have as much clear view of the lung fields as possible, as well as preventing a pseudo cardiomegaly. Of course, not all the time you can order a PA film. Sometimes when patient has pneumothorax, active cardiac chest pain, he's unstable, unable to cooperate with the procedure, oftentimes you might have to resort with ordering an AP view. So that's the idea behind this case, is always assume the film, always think of the film, and always think of the exposure. Is the exposure right or not? So that's the idea behind this case. In case number 2, we have a patient presented with acute shortness of breath. So what's the possible diagnosis? So here we have a case of a chest X-ray, could be a PA or AP view. But what's notable in this finding is that you can see in the left lung field, it is hyperinflated. It is hyperinflated and it's consisting purely of air. And notice that in the lung parenchyma, there is no bronchial markings. What I mean is that there is no pulmonary blood vessels, which are whitish in structures. They're not visible in the left lung field. So you got a left lung field that is mostly composed of air and it's hyperinflated. And on top of that, you can see on the right lung field, you can see that most of the mediastinum, they have been compressed towards the other side. They've been compressed contralaterally. So if you have a hyperinflated air, and if you are able to see the visceral line of the lung, but let's say you have a hyperinflated air or hyperinflated lung with absence of bronchovascular markings, and it's just purely composed of air, and there's shifting of the mediastinum contralaterally, then you start to think that this is a case of tension pneumothorax or left-sided tension pneumothorax in that case. So you can see the difference. The trachea, the mediastinum, including the heart, they're all been shifting contralaterally. Oftentimes in pneumothorax, you'll see the visceral line of the lung. That means that part of the lung that's compressed, you can see the line of it, the visceral line or the visceral pleura. You'll see it visible as a thin white line, but it's not as visible in this picture because this left lung, it has been pushed towards the other side. So this is a severe case of left-sided tension pneumothorax. Just keep in mind as we go through each case, you should keep in mind that oftentimes what helps in making the diagnosis is the patient's history. Basically, what helps in getting the diagnosis from chest X-ray is by knowing the patient's case. So a patient coming to you with acute shortness of breath, you can think of it as either a respiratory problem, oftentimes, or even a cardiovascular problem. So let's look at the next case. Now the next case is interesting. This is practically a PHX view. We can see the hemidiaphragm, they are fine. The costophrenic angle, they are sharp. If we look at the lung parenchyma and the ribs, they're all relatively fine here. All right. You look at the right side or the left side, they're also completely fine. If we look at the mediastinum, they're relatively normal. So everything is pretty much normal with the exception of this. Here you can see an area of ossification. And this area of ossification, it's practically in the upper part of the lung. It's mostly within the mediastinum, and it's practically surrounding the trachea. So I have this ossification that suggests it's either consolidation or soft tissue density. Now this is more than likely to be a soft tissue density mass that's present within the mediastinum. So this is more than likely to be a mediastinal mass that is occupying near to the trachea. So again, the patient's history is important because if I told you that this patient is presented with a case of weight loss, a case with irritability, and this patient has a family history of hyperthyroidism, and you look at this case, then you assume this is a case of goiter. So this is what we're looking at here. This is a severe case of retrosternal goiter. There's more than likely to be a soft tissue mass that's causing a compression on the trachea itself. And this is very, very obvious, not even without a chest X-ray, especially if you do clinically percussion over the sternum or the manubrium sterni, and there's dullness that suggests retrosternal goiter, which by the way is one of the many differential, we could say even on the CT scan on the same patient, this is one of the many differential diagnoses of anterior mediastinal masses. So here we have a CT chest, here we can see the trachea, and you can see in front of the trachea, between the manubrium sternum and the trachea, this is the mediastinum. And this is specifically here an anterior mediastinal mass because it's in the interior of the mediastinum. There's an anterior mediastinal mass that is compressing the trachea towards the other side. And again, there's many differential diagnoses. One of them is more than likely to be a retrosternal goiter, but it can also be a cymoma. It can also be a teratoma. It can be a descending thoracic aneurysm. So it all starts with T. Anything with a T. Lymphoma, terrible lymphoma. So with lymphoma, it can present with an anterior mediastinal mass. Oftentimes, X-ray is not enough. You might order a CT scan to further visualize the mass, not just on its appearance, but also on its location. All right, so that's one thing to keep in mind is, you could have a soft tissue density mass, especially causing compression of the trachea. Now let's look at this next case. This next case is interesting because here we have a case of person with shortness of breath and weight loss. And here immediately you have a PA chest x-ray showcasing to you very interesting findings. If you notice, these are pulmonary nodules that are whitish in appearance, and they are spread out. They're not focal, they are diffuse. So if you have a diffuse pattern of pulmonary nodules all over the zones of the lung or all over the lobes of the lung towards the right side and the left side with shortness of breath and weight loss, you start to think of differential diagnosis. This could be miliary tuberculosis, especially people with reactivation of TB. With miliary TB, they could present with this finding. Another one is metastasis. Someone with metastatic cancer, so lung cancer, colorectal cancer, prostate cancer, and they metastasize towards the lung, they can present with this finding. Even in some cases such as histoplasmosis, a fungal infection, in severe cases, they can present with this finding. So again, the patient's history as well as the patient's chest x-ray, they come together, they match up with one another. So you can see the presence of multiple pulmonary nodules spread out, giving you a whole bunch of differential diagnoses. All right, we cannot assume elsewise. And again, if you want to localize the differential diagnosis here, you'd order a CT scan, again, to visualize your findings as well as localize your findings. All right, localize their findings, their location. So let's look at the next case. The next case is, again, we have a person with shortness of breath and right-sided chest pain with a history of exposure to asbestos, which is a very toxic chemical towards the lung. So again, I'm thinking of a respiratory case. And what is the most likely diagnosis I could get alone from the patient's history? I can think of mesothelioma or a pleural malignancy. Why? Because this patient is more than likely to have interstitial lung disease in the form of asbestosis, and that led to more than likely, if long-term case, that led to the development of pleural malignancy or mesothelioma. And how does mesothelioma appear? Well, let's look at the chest x-ray. Here in this chest x-ray, if we immediately look at the area of the left hemidiaphragm, we can see what is known as a ciliate sign. What do I mean by ciliate sign is that you can see that the edges of the left hemidiaphragm, they're obscured because there's a soft tissue density mass here. It's loculated and it seems to be coming from the pleura. The pleura is, by the way, invisible, of course, on chest x-ray, but we can make out of it here in this case. So we can say that there's a soft tissue mass, more than likely to be an intrapleural mass that's loculated in appearance, and there seems to be a ciliate sign in association with the edges of the left hemidiaphragm. So you get this finding, you combine this finding with the patient's history, and you're more than likely to assume that this patient is more than likely to have mesothelioma. All right, this might be a pleural plaque. He might have a pleural plaque that is large in appearance. And you can also clearly see that if we compare the right lung field with the left lung field, you can see some differences. Look at the lung volume on the left compared to the right. It is changed here. And let's look at the pleura. Look at the pleura on the left side, which is invisible. It's very thin in appearance. Look at the thickness of this pleura on the left side, and let's assume it's there. Compare this side, compare the left side to the right side, and you can see there's some thickening of the pleura, suggesting there is growth here. So there's thickening of the pleura, and there is a loculated mass as compared to the left side. And you can see that this portion of the lung has more lung volume as compared to the right. So this finding, in combination with this patient's history, you're thinking again a pleural malignancy or mesothelioma in that case. All right. Of course, just remember that you don't always stop at the obvious finding. Whenever you're reviewing a chest x-ray, you want to look for other abnormal findings. So you might look for pulmonary nodules, which is not found in this chest x-ray. But again, never stop at an obvious finding. Keep continuing your search at other areas. All right. So that's the idea behind the case. Look at this one. We have a case number 6. So a person fell from height and now he has trauma to the chest. If a person has trauma to the chest, there's a whole bunch of scenarios. All right, this might be an emergency case. So we ordered a chest X-ray, and we can notice here there's some very obvious finding. All right, so this is a PA chest X-ray. Again, the lung fields are clear. The chest, the heart size is normal. If we look at the left hemidiaphragm, they're normal. The costophrenic angle, they're normal. If we look at the right lung field, we can see that overall they look normal. The ribs, there's no subcutaneous emphysema, for example. There's no broken ribs that we can see here. The mediastinum relatively is fine. The hilum, there's no lymphadenopathy. Again, you make your search. Now, if we look at the left lung field, there's something very interesting here. If you notice, you can see there's a thin pleural line here. All right, if you can notice it here, there's a thin pleural line of the left lung, suggesting that we're looking at a portion of the lung that's being collapsed. Again, if you see a thin white pleural line, this suggests to you pneumothorax. That tells to me that there is air here that's compressing the lung on the left side. So that's why we're seeing the thin pleural white line, because there's air between the parietal and the visceral pleura. There's air within the pleural space that's compressing this poor left lung, and therefore we're assuming that this patient has simple pneumothorax. We will not say tension pneumothorax. Why? Because there's no shifting of the mediastinum. And also, oftentimes tension pneumothorax does not require imaging for diagnosis. All you need is clinical diagnosis to diagnose tension pneumothorax. So this is a case of simple pneumothorax to be more than likely the case. All right. And also, if you notice the ribs here, there is fracture of the ribs. There is a very subtle, simple transverse fracture of what appears to be the fourth rib. Appears to be the third or the fourth rib of the posterior rib. That is. All right. So again, we're going to say this is a left simple pneumothorax in that case. Let's look at case number 7. So in case number 7, here we have a case of a chronic mild shortness of breath, and again, this person was exposed to asbestos. So you're thinking worst case scenario. And immediately when I look at the chest X-ray, I see the presence of what appears to be pleural plaques. There are multiple large pleural plaques. And again, when you have asbestosis, you have it in the case of interstitial lung disease. Here in this case, we have a person with interstitial lung disease that is so severe with the presence of pleural plaques. They're large in appearance in this area, and you can find it in this area, and you can find it in this area, and you can also find it in this area. So this guy, he has asbestosis with mesothelioma, which presents in the form of intrapleural plaques. All right. So again, the patient's history helps localizes the diagnosis. It helps narrow the diagnosis. But again, even if you find the obvious findings, don't stop searching there. Look for other findings. I'm also concerned for lung cancer, for example. I'm also concerned with other incidental findings. But in this case, we'll say this is a case of interstitial lung disease with mesothelioma. Again, it's an obvious finding, which appears, as you might notice, as a soft tissue density mass. Now let's look at case number 8. Here we have a person who's a lifelong smoker with weight loss and increasing shortness of breath. So if you notice, if we look at the right lung field, if we look at the hemidiaphragm and the costophrenic angle, they're fine. The ribs, they're fine. The fat, they're fine. The ribs, the lung parenchyma, overall, the right lung field, it's fine. The mediastinum, the trachea, everything looks fine. But if we look at the obvious finding, we can see here that there is a ciliate sign. What do I mean by ciliate sign? Well, let's look at it step by step. If we look at the the right hemi or the left hemidiaphragm, we can see the left hemidiaphragm is nowhere to be seen. Also, we can see the costophrenic angle. It is nowhere to be seen. It is obliterated, or it's obstructed, or obstructed. Let's say it's obstructive. Sorry. So I'm first immediately assuming if the costophrenic angle is nowhere to be seen, there is at least pleural effusion. On top of that, if there's pleural effusion, that means there's accumulation of so much fluid in specifically the lateral costophrenic angle. So if there's so much fluid accumulating in the costophrenic angle, that means this fluid, it will cause a ciliating sign with the left hemidiaphragm, where two places of the same density, they come in contact with one another and they cause a ciliate sign, loss of the edges of, let's say here, the left hemidiaphragm. So I'm assuming right off the bat, this ciliate sign is more than likely to be, it's more than likely due to a left-sided pleural effusion, due to obstruction of the left lateral costophrenic angle, and we have a left, moderate size pleural effusion. It's been accumulating, and it's been accumulating until it took the appearance of a meniscus sign. So the reason there's a meniscus sign is because there is less elastic recoil. Oh no, there is more elastic recoil of the lung. So what this means is that the fluid, it will, distribute itself somewhere else. So it will take the appearance of a meniscus sign, similar to the knee, which is U-shaped in appearance. But regardless of all that point, what we want to mention here is that with this patient's clinical finding, and with this patient's X-ray finding, we're more than likely to assume that this patient has a left-sided pleural effusion. And of course, we will not stop there. We always want to assume if this patient has pleural effusion, what might be the cause? Is it exudative or transudative in appearance? With this patient's history, we might be assuming that this patient might have lung cancer. He might have squamous cell carcinoma. He might have small cell lung carcinoma, because these are lung cancer associated with smoking, and he has the clinical presentation up to boot. So this pleural effusion, it might be exudative in appearance. It might be associated with lung cancer. So we would order here a CT scan, to see and look for any pulmonary nodules that we might have missed here. But regardless, this is a left-sided moderate pleural effusion due to maybe squamous cell carcinoma, due to maybe or maybe due to small cell lung carcinoma, or squamous cell carcinoma, or even bronchogenic carcinoma. We don't know. All right? So this is for case number 8. Let's look at case number 9. This is an obvious finding. My diagnosis, or my incidental finding, is that this patient has everything normal, except for the finding of bilateral hilar lymphadenopathy. So the hilum, as you know, contains of veins, consists of arteries, consists of nerves. The hilum composed of your lungs within the center. And obviously, what might be obvious here is that the lymph nodes specifically, which is also present in the hilum, they are enlarged. So if you have enlargement of the lymph nodes within the lungs hilum, the right side and the left side, you start to think of a lot of differential diagnoses. There's no specific diagnosis. You need to narrow it down by ordering a CT scan. So in this case, you might be thinking this patient might have sarcoidosis if he has dyspnea and dry cough for long periods of time. You might also be thinking lymphoma. You might also be thinking tuberculosis. You might be thinking even pulmonary arterial hypertension, albeit it would be larger in size than that. So there's many differential diagnoses. Again, the patient's history, and by ordering a CT scan of the chest, you might narrow it down. So idea is, again, look for the incidental finding. This is a bilateral hilar lymphadenopathy. You can tell it's hilar lymphadenopathy based on the location and also in its appearance. It's loculated in appearance. It's lobulated or loculated in its appearance, suggesting lymph node that's being enlarged in this case. All right, so that's the case for case number 9. And for the last case, case number 10, if we look at case number 10, again, we have a PA chest x-ray, and we can immediately find that this is a device that's being hooked into this patient. The device that's being hooked into this patient is a pacemaker, and this pacemaker is a one lead pacemaker. This pacemaker has a one lead that's more than likely to be inserted in the right atrium. Remember, the right border of the heart is made by the right atrium, and again, there's a one lead pacemaker that's been inserted on the right atrium. So we can assume this patient has a cardiac issue. Now, if we look at our search pattern, again, look at the right hemidiaphragm, look at the costophrenic angle, you investigate you investigate for the right lung field, it's normal. The mediastinum, in appearance, it might look normal. And if you notice here, there's something very obvious here, all right? What's very obvious is that if we look at the mediastinum more specifically within the heart, we can see that the heart, it's enlarged. So if we have what we call a cardiothoracic ratio being done here, if we do the cardiothoracic ratio, we would notice it's more than 50%. The heart is more than, it makes up more than half of the lung parenchyma, If we compare, the vertical or the horizontal diameter of the heart, you divide the horizontal diameter of the heart over the horizontal diameter of the lung. So there is, if we were to measure it through cardiothoracic ratio, it'd be more than 50%. So there's a clear-cut case of, cardiomegaly. You know what I mean? And on top of that, if we look at this case over here, if we zoom in on further on this picture, for example, if we zoom in this picture, the same patient, we might notice a very, very incidental finding, very subtle finding. And that is the fact that there is prominent vascular markings, or let's say prominent interstitial markings. Like we said in previous videos, oftentimes when we look at the lung parenchyma, often it will compose of pulmonary blood vessels, which are very obvious in the center. But as these pulmonary blood vessels, as they divide themselves towards the periphery, they become smaller and smaller in appearance because, they distribute themselves towards the periphery. They become smaller in appearance and less obvious in appearance, or less whiter in appearance and density. There it is. But if we zoom in through a radiologist, we would see that there is very obvious interstitial markings. That means the pulmonary blood vessels, they're obvious towards the periphery. That means to us that this is a sign of interstitial lung disease in a reticular pattern, in a line pattern. And you can look at previous videos in such case. Now, if we have a case of interstitial pattern, if we have a case of pulmonary blood vessels being very obvious in a reticular pattern towards the periphery, we always want to assume this is interstitial lung disease in a reticular pattern. And we can also assume this might be, especially with cardiomegaly, we might always assume this might be interstitial pulmonary edema. This is another differential diagnosis. So this could be interstitial pulmonary edema. We might be in the early stages of heart failure, or this might be a case of interstitial lung disease with reticular pattern, all right? Oftentimes, another differential diagnosis as to why we might have interstitial lung disease with a patient with pacemaker, we might always assume that this patient might use amiodarone. And amiodarone is an antiarrhythmogenic medication that can cause pulmonary fibrosis in a patient with a cardiac condition. So this is a differential diagnosis. So to summarize, we have an obvious case of very obvious interstitial markings or very obvious pulmonary vascular markings in the periphery in the same patient. This could be an interstitial pulmonary edema, or it could be a case of interstitial lung disease in a reticular pattern due to maybe the use of amiodarone. You know what I mean? It could be the use of amiodarone since this patient has a cardiac condition. All right? So that is what we have as our differential diagnosis. If I had to choose between the two, I would choose the amiodarone, but again, we need the patient's history. All right? That's pretty much it for case number 10. We will look at the upcoming cases in the next video.